Good afternoon and welcome to today's webinar, Learning from the Flint Water Crisis, Legal Implications and Community Public Health Impacts, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Charles Strong, the Digital Marketing Coordinator at the Network for Public Health Law's National Office, and I'll be your host for today's webinar. Please feel free to submit questions at any time during this webinar by using the Q&A tab on the right-hand side of your screen. So all you need to do is click on that tab, select all panelists from the Ask drop-down menu, and submit your questions. Your moderator for today's webinar is Peter D. Jacobson. He is Professor Emeritus of Health, Law, and Policy at the University of Michigan School of Public Health and the President of the Public Health Law Association. Professor Jacobson is also the co-director of the Network for Public Health Law's Mid-State Region Office, and his current research interests focus on the relationship between law and healthcare delivery, law and public health systems, and health equity. He'll be leading us through the rest of today's webinar. So Peter, over to you.
Okay, thank you very much, Charles, and thanks to everyone for joining us in this webinar. The Flint water crisis may have receded somewhat from public attention, but it certainly hasn't receded from the lives of Flint residents. And that's why we wanted to present today's webinar. It will be in two parts. In the first part, we're going to provide an overview of the results of a the Beaumont Foundation-funded study looking at how the legal structure contributed to the Flint water crisis. But more importantly, a major purpose of the webinar is to give greater voice to Flint residents and community benefit organizations about how they view the crisis and current efforts to recover from the Flint water crisis. To present the legal issues, we have Colleen Healy-Bouffides and Jennifer Bernstein from the Mid-States region of the Network for Public Health Law. Colleen is a senior attorney with Mid-States. Before joining the network, she worked on state and federal legislative and administrative advocacy for Michigan's federally qualified health centers, and before then as a commercial litigation associate for a large Michigan-based law firm. Jennifer is the deputy director of the Mid-States region. Before coming here, she was a Hogg Foundation Mental Health Policy Fellowship awardee working for Lutheran Social Services in Austin, Texas. During the 82nd Texas legislative session, she advocated for the expansion of trauma-informed care throughout the state. We're also fortunate to have two Flint residents with us who will be presenting their views and views of their organization on the crisis. First, Dr. Kent Key is the director of the Office of Community Scholars and Partnerships at Michigan State University, and he's also the executive deputy director of the community-based organization Partners, the founder of the Community Ethics Review Board, and he's also a fellow at the Robert Wood Johnson Foundation through their Culture of Health Leaders program. With him is Naira Sharif, a grassroots organizer based in Flint. Naira was one of the co-founders of the Flint Democracy Defense League, a grassroots group formed to confront Flint's emergency manager in 2011. Naira is currently the director of Flint Rising, a coalition of Flint residents and community groups, labor, and progressive allies that formed in response to Flint's emergency declaration. She has nearly 10 years' experience organizing around local, state, and national electoral and issue campaigns. With that, I'm going to turn it over to Colleen. And again, as Charles said, please submit questions for us to consider.
Thanks, Peter, and thanks everyone again for joining us. Jennifer and I will talk today about the contribution of law to the Flint water crisis, and we'll describe some of the legal and practice changes that could be made to prevent a crisis like this from happening in other cities. Very briefly before we get started, I will just give a quick overview of the facts. In April 2014, while the city of Flint was under the control of a state-appointed emergency manager, the emergency manager changed the city's drinking water source as a cost-saving measure, switching the city from receiving treated water from the Detroit water system to treating its own water drawn from the Flint River. The Flint River water was very corrosive, but was not treated with anti-corrosive agents, and this allowed lead from the pipes to leach into the city's drinking water. There were immediate water quality concerns from residents, but the emergency managers insisted on continuing to use the Flint River, and in fact the city was prohibited from switching its water source back to the Detroit water system even after the financial emergency ended. The water crisis was finally revealed to the public when two private actors, Dr. Mark Edwards of Virginia Tech and Dr. Mona Hanna-Attisha of Hurley Medical Center, reported elevated water and blood lead levels in Flint in August and September of 2015. In October of 2015, the city was finally able to switch back to receiving treated water, but by this time, Flint residents had already suffered significant lead poisoning and an outbreak of Legionnaire's disease. So I will talk first today about what went wrong from a legal perspective by looking at the relevant legal framework in Michigan, including public health and safe drinking water laws and Michigan's emergency manager law. And then Jennifer will talk about laws used in other states to address local fiscal distress. The premise for our legal research is that the water crisis wasn't inevitable. It raised many political, societal, and ethical issues, and it involved a very complex set of laws. There are two relevant legal frameworks to examine when looking at the Flint water crisis: the Safe Drinking Water Framework and the Public Health Legal Framework. Gaps in areas of overlap are somewhat inevitable where two distinct legal frameworks come together because the separate laws don't always fit together well. So we focus on analyzing the frameworks individually and then at their intersection. I'll talk today about both structural legal flaws, which are problems with the laws themselves, and implementation issues, which are failures to properly perform a function that is required or allowed by the law. In Flint, the appointment of an emergency manager added to the complexity that already existed at the intersection of public health and safe drinking water laws. So our key legal question was, given the appointment of an emergency manager, what legal authority could other governmental entities have used to avert or mitigate the crisis? Our first step in answering this question was to map out the legal framework that existed without an emergency manager, so focusing just on the public health and safe drinking water laws. This existing legal framework was complex for a number of reasons. There were multiple laws at play, including the federal and state Safe Drinking Water Acts and the Michigan Public Health Code, as well as local environmental health regulations. There were also multiple agencies and multiple levels of government involved. So there were federal, state, county, and city agencies, and both public health and environmental agencies involved. To make sense of these distinct and complex legal frameworks, we mapped the laws according to different public health functions on matrices like shown on this slide. So we used the public health functions of prevention, surveillance and detection, investigation, and intervention so that we could more easily determine where the gaps were. Then we combined the two matrices into one to get a complete picture of relevant legal authority in Flint as it existed, again, without an emergency manager. So this matrix shows the combined analysis with our specific focus on lead and Legionella. On this matrix, the blue X's represent safe drinking water responsibilities and the green X's represent public health responsibilities. And I'll just mention a few key points about the legal context and some takeaways from this matrix. So first, with regard to safe drinking water, is the issue of primacy. The Federal Safe Drinking Water Act creates a framework for drinking water regulation that in most states, including Michigan, places primary enforcement responsibility at the state level, but retains authority for the Environmental Protection Agency to intervene if needed. The lead and copper rule is a federal regulation with a state analog that was particularly relevant in Flint. The rule requires public water systems to treat the water with corrosion control treatment unless the system has been deemed to have optimized corrosion control already. In Michigan, responsibility for implementing and enforcing the Safe Drinking Water Act has been assigned by the governor to the Department of Environmental Quality. The Michigan DEQ improperly interpreted the lead and copper rule, and that is what allowed lead to leach into the water in Flint. A few important points about the public health framework are that first, states hold primary public health legal authority, with the CDC assisting with interstate issues and upon request by states. Michigan's public health code creates a system in which the state health department and county health departments have parallel authority. So they both have broad authority to investigate and intervene when the public's health is threatened. The state can take over local health functions anytime a county fails to perform them. An important point is that public health does not play, in Michigan, does not play a role in preventing health threats associated with drinking water because this function is assigned to the DEQ. Finally, note in this matrix, which again shows the context without an emergency manager, that the mayor and city council would have been responsible for the decision to switch the water source and for budgeting enough money to support that change. The city's public water system, which is overseen by city officials and MDEQ, would have had primary responsibility for preventing public health harms related to safe drinking water. This slide shows a few of our key recommendations relating specifically to public health and safe drinking water. Our key structural recommendation for both safe drinking water and public health laws is that there should be a stronger legal role for public health agencies in both permitting water systems and enforcing safe drinking water laws. One of our key implementation recommendations for safe drinking water is that environmental agencies should increase communication with public health agencies, such as by reporting water treatment changes, Safe Drinking Water Act violations, and waterborne disease outbreaks so that public health agencies can take timely action. For public health, one of our implementation recommendations is that public health agencies should rigorously employ their generally broad public health authority to monitor, investigate, and intervene in response to a public health threat. To do this effectively requires legal preparedness, so practitioners need to be fully aware of and equipped to use their public health legal authority so that they can act quickly when needed. Our next step was to analyze Michigan's emergency manager law and determine how it affected the existing legal framework. Under Michigan's emergency manager law, if the governor finds that a municipality is experiencing a financial emergency, the municipality has 4 options for what happens next, but the emergency manager option is the strategy most often used. If this option is selected, the governor appoints an emergency manager for the city. Once appointed, the emergency manager temporarily supplants the governing body and the chief administrative officer of the local government. So local officials are stripped of all powers unless the emergency manager specifically authorizes them to retain certain functions. This means all executive and legislative functions at the local level are vested in the emergency manager. The emergency manager is overseen by the Michigan Department of Treasury and is protected from liability like a state employee. According to the emergency manager law, one of the key purposes of an emergency manager is to assure continued provision of services necessary to the public's health. This slide shows one reference to public health in the law, and there are a couple of others. But the law does not include any guidance for operationalizing this requirement, such as criteria for making decisions or a requirement to consult with local or state public health officials or the community. When you add the emergency manager and treasury, who oversees the emergency manager, to the existing public health legal framework, there are 2 significant changes. The first is that the city mayor and city council have no authority while under emergency management, and that authority is transferred to the Treasury and Emergency Manager, which is shown in the red box on this slide. This creates a huge imbalance of power because now the state holds almost all authority in Flint, and that's shown by the greenish box. But it's important to notice what didn't change also, which is that everything else at the state level and everything at the federal and county level stayed the same, including state and local public health authority to investigate and intervene. This slide shows the structural flaws we identified for the emergency manager law, a few of them. One was the lack of democratic accountability to Flint residents, since Flint residents lost all local representation in city operations, since neither the emergency manager nor the Treasury was accountable to them. Second is the lack of explicit requirements or procedures for emergency managers or Treasury to consider public health in decision making. The law does not include any specific guidance on how to balance public health with cutting costs. And lastly, I have a few of the implementation failures that we identified included here. One is that the emergency manager failed to recognize the breadth of his mandate, which included assuring the continued provision of services essential to the public's health, and failed to understand that his mandate went beyond balancing the budget. Second was that the Treasury failed to provide adequate oversight to make sure that this was happening. And third was that the governor and many other agencies failed to appropriately consider and investigate and respond to public complaints, even though the state had assumed all legal power and responsibilities in Flint. So with that, I will turn it over to Jennifer to talk about alternative approaches to local fiscal distress that might provide more protection for the public's health.
Hello. Okay, so I'm going to be talking about a comparative analysis of emergency manager laws and recommendations. So I'll first start talking about some of the critiques of the Michigan's emergency manager law. First, it's had a pretty controversial history. There have been several iterations of the law, and most recently there was an amendment that was passed in December 2012, and this was shortly after voters had rejected the law via referendum in November 2012, and the new iteration of the law actually prevented voters from changing the law via referendum or retracting it either via referendum. Also, the law has been seen as anti-democratic. As Colleen mentioned, there's no local government representation once the emergency manager has taken over. The city council and the mayor has no authority, and so a lot of controversy around that. It also, the law fails really to address the causes of fiscal distress, but rather just addresses the symptoms. It really is focused simply on balancing the budget and ridding the city of debt, but it doesn't prevent future fiscal emergencies by addressing more systemic problems with the city. So if the city has a disappearing tax base or other issues that are causing fiscal distress, the emergency manager doesn't address those issues. And so the city might be faced with a continual cycle of fiscal distress. And that can actually be seen in Flint, since there was actually 2 occurrences of an emergency manager being installed in the city. One more recently and the other in the early 2000s. Also, the law disproportionately has been applied in communities of color. There have been 9 cities and 3 school districts in the state of Michigan that have had an emergency manager installed. Some of those minority-majority cities include Flint, Detroit, Benton Harbor, and Highland Park. So the emergency manager laws generally our study, we looked at 20 states that authorize state intervention in local government. We used the Pew Trust study as our starting point, the study State Role in Local Government Fiscal Distress. The scope and nature of interventions varied widely between states. Michigan's is actually one of the most aggressive that we found, but the variations went from went from strong powers to intervene by the state and take over local government to some more supportive laws that looked at playing a role to support local governments in working through fiscal distress themselves and the state providing technical assistance. And based on our sample of 10 states with emergency manager laws, we found that most do not require community involvement in decisions. Most do not require consideration of public health in decision making, and several protect emergency managers from legal liability. So one example that I wanted to give of a state that provides higher democratic representation is Rhode Island. In Rhode Island, the emergency manager entity is actually the Budget Commission, and that Budget Commission includes 5 members, 2 of which must be elected local officials, including the chief executive for the city, such as the mayor, and at least 1 city council member. This is much more protective of the community because they have local representation on the board that's making decisions. As you can see, it's only 2 out of 5, so it's still not a majority of the council, but it does give a voice to the local community. Powers of the Budget Commission are enumerated in Rhode Island, which is also more protective. The powers are limited and they're well defined. And those include levy and the ability to levy and assess taxes, make or suspend rules, adopt a municipal budget, approve collective bargaining agreements and amendments. Now, there are states that we looked at without any emergency manager laws. There are 3 different schemes for these states. Blanket authorization to file for municipal bankruptcy, and this is allows any local government entity to file for Chapter 9 bankruptcy, and therefore it leaves the decision in local government control as when to or how to pursue bankruptcy. There's also conditional municipal bankruptcy authorization. This is when the state usually must approve local government plan to file for Chapter 9, and it also usually means that there are oversight mechanisms that kick in for the state to oversee the local government and the bankruptcy proceeding. And then there are local governments that are not authorized to file for bankruptcy. In this case, there's no avenue for local government to file for Chapter 9, and our research shows that in states with no authorization and no emergency manager laws, generally no major municipalities actually experience major fiscal distress. And then once that actually happens, states seem to pass laws, either emergency manager or bankruptcy laws, to allow states to deal with that. So another example in this realm, Colorado, Missouri, and South Carolina provide blanket authority for a broad range of local government entities to utilize Chapter 9 bankruptcy laws. It allows local governments to determine their own needs. It also allows local government to continue self-governance, and states do not provide any additional intervention programs to assist distressed local entities. So there are pros and cons to this approach, it seems. You have greater local control, but less assistance from the state. Emergency manager law recommendations. I'm going to go through these pretty quick. I think I'm running low on time. So we have structural recommendations. This is requiring consideration of public health in decision-making, requiring community engagement or even democratic representation, replacing single emergency managers with a 3-person team, including a local ombudsman, so something that might reflect more what Rhode Island is doing. Prohibit the cost from being the primary factor in decision making, and also considering things such as health and safety. Consider imposing fiduciary duty standard on emergency managers, so really holding emergency managers responsible to the community. Implementation recommendations: develop rigorous public participation and oversight in the process. Develop criteria for emergency manager decision-making that includes public health. Recognize limits of emergency manager expertise and require expert consultation. Treasury must independently review all decisions rather than simply rubber stamping the decisions of the emergency manager. Legal preparedness of other agencies is crucial, and understanding the powers and authority and when they have the right or duty to act. So in conclusion, MDEQ had the primary legal authority and responsibility for safe drinking water, but they abdicated their essential and unique responsibilities. Several agencies had authority to intervene, but gaps, overlaps, and inconsistencies in the legal framework impeded timely action. Relevant laws included checks and balances, but it was not self-executing. A policy of deference does not work absent communication and cooperation. And finally, the emergency manager's jurisdiction undermined the local city and county government's ability to respond to the crisis. It also eliminated local democratic accountability. Inadequate legal preparedness contributed to the failures of implementation, especially regarding communication and coordination across agencies. I just want to briefly acknowledge that we received support for this project through a grant from the de Beaumont Foundation, and that the Network for Public Health Law is a national initiative of the Robert Wood Johnson Foundation. And I'm going to pass the slides now to Kent.
Good afternoon. So we want to kind of talk more of the experience that we, the residents of Flint, lived as we went through this water crisis. So the first thing we want to talk about is that there was a threefold crisis. People just say the water crisis, but as just so eloquently laid out, there was a democracy crisis through the emergency manager law. Then that led us to a water crisis, which there was more than just lead in the water, but that's what got everybody's attention. And that water crisis then led us to a long-term public health crisis.
So the emergency manager law, which was initially enacted in March of 2011, gave the emergency manager the power to sell off public assets, dissolve municipalities and school districts, renegotiate union and vendor contracts, hire and fire employees. When an emergency manager came into your municipality or school district, it absorbed the powers of two branches of that local government or school district. For a municipality, it was the executive and legislative branch, and for a school district, it was the school board and superintendent. But the one thing that the emergency managers did not have the power to do was to renegotiate bond payments. So the bondholders were paid on time and in full. Once the Michigan residents voted it down in November of 2012, the lame duck session of that year passed a replacement law, Public Act 436, in December 2012. And it had a $30,000 appropriation to make it referendum-proof by way of our state constitution.
So the water crisis affected residents physically, mentally, and financially, to say the least. And then it created a long-term public health crisis that residents are to this day still addressing, not to mention that trust has eroded with most levels of government in our community. And then our undocumented population received a lot of stress from this experience. Many of them, in the beginning of it, was informed by their family from the country of origin because there was no state documents or anything prepared by the government that communicated or translated the warnings or any of the language in Spanish. And then there was also fear for deportation. We have had several families in our community tell us that when government officials went to deliver water and knocked on the door, that ICE was standing with them, and many loved ones were deported in that process. So earlier on, immediately after that, in 2015, we requested a community health analysis.
Yeah, and after the public health declaration that was passed by the Genesee County Board of Health in October 1st, 2015, we requested a community health analysis because we knew that we really need to document what was happening, and that was really reiterated when we decided to actually go door to door to speak to people, because we still had several pockets of the population that did not know that there was a crisis. And as we were going door to door, we could tell through anecdotal information that there were clusters of diseases that were out there in the community. We would go on a block of 20 homes. We may speak to 10 people, and 6 or 7 people have been adversely impacted through waterborne illnesses. And we vehemently requested and really had physicians who were echoing that, but we did not get any sort of response from the state. So in the interim, and still to this day, like, we've had people who have moved, people who have moved out of the community, out of the state, people have died, and now, like, even though we are beginning an analysis, we know that that there's a lot of data that's been lost.
So the public health response on the ground in Flint, immediately once the world found out about this, community members, faculty from U of M, Michigan State, and some representatives from the health department, we launched a Flint water course, which was a course that was free to residents. It was a one-credit course for students, but it was basically a safe place for community to come and to vent and to first be exposed to experts across disciplines, so public health experts, medical experts, engineering experts, water experts, communications experts, and actually all of those sessions are archived on YouTube. If you would type in Flint Water Crisis Course, there you're able to watch them. Shortly after that, the Healthy Flint Research Coordinating Center was created. I founded the Community Ethics Review Board to ensure that community was not being taken advantage of by research efforts. The Flint Center for Health Equity Solutions was created, and also we got past health equity in all policies in Genesee County. Finally, the ReCast project was funded by SAMHSA here in Flint, and then we had several discussions about the lead and copper rule here. So to start specifically with the Flint Water Crisis Course, again, that was a safe place where residents were able to come, to listen to experts, answer their questions, and then also give them a platform to actually ask questions. So many of the residents felt it was a trusted place to receive information and to exchange, and on average, 65 to 100 attendees attended each session. The Healthy Flint Research Coordinating Center was organized by University of Michigan, both Ann Arbor and Flint campus, Michigan State University, and Flint Community Partners. It was organized to create synergy in research and foster ethical and respectful academic community partnerships, and to develop solutions to community-defined issues. The center aided to coordinate research because we became a fishbowl for research, and we knew that there was a need for coordinating so that to reduce the burden on an already traumatized and stressed community. And the goal was to serve as this point of contact for researchers who wanted to come into Flint, that this would be almost the port of entry for them so that they can then go through the mechanisms that are set up through the HFRCC. Two of the mechanisms are, we have an open data Flint, where we felt it necessary that community have access to the data that's happening in Flint. And so each researcher that comes to the HFRCC signs permission to put their data on this Open Data Flint platform so that community members and organizations can also utilize the data to help inform their programming and their funding initiatives. And then we also have an index, a Flint Project Index, because so many people were doing similar things, and we felt that it would be better to have collaborations, again, to reduce the redundancy and the burden on the residents. And so people could go and log their projects and what the aims of those projects were, and then able to find out who the contact persons were to create those collaborations. We also had a series of community dialogues to hear exactly from community what they felt was going on as far as the water, what they felt the research needs and the priorities were. And then we had some community academic events where we hosted on MSU and U of M's campus in Flint, where researchers from those campuses, but also from Wayne State, Central Michigan, and others came to actually talk about research interest. We were able to pair them with possible community groups who may have had a similar interest. And then we also had a reverse research day where the community actually went and looked for researchers who could help them achieve their community agenda. The Community Ethics Review Board, it reviews proposed Flint research projects and proposals to ensure community-level protection considerations. Knowing that the IRB, or the Institutional Review Board, looks at the researcher and the subject and reviews protections on that in that scope, it was important that there was a mechanism in place that looked at the ethics and the protections of the community. How does this research benefit the collective community? Is there mutual benefit? How is community engaged in this research? And then how will the data be shared with the community to move forward? Those are some of the things that the SERB, which is its nickname, looks at when reviewing, and they host a formal review where they have a primary, a secondary, and a discussant, and they go through their criteria when they meet with the researchers, and then at the end of that, they either grant a letter of support to a researcher or they do not. And many of the community groups, neighborhood associations, and faith-based groups will not participate in a research project if they do not have the support of the Community Ethics Review Board. The Flint Center for Health Equity Solutions focuses its research efforts on health disparities and chronic disease that cross boundaries and directly affect Flint and Genesee County. It is a Region 5 grant, so it covers Michigan, Illinois, Indiana, Minnesota, Ohio, and Wisconsin. It has two main approaches. It looks at behavioral health and physical health through the Church Challenge and then through the Strengthening Flint Families project. The crucial thing about this particular initiative that happened post the water crisis was that it was looking at forwarding and promoting health equity in all of our solutions, and remembering and reminding folk that Flint had a lot of public health and health disparities before the water crisis. The water crisis was just another issue that Flint residents had to deal with. Dr. Mona Hanna-Attisha, her pediatric public health initiative was set up to bring experts in pediatric and child development, psychology, epidemiology, and other genres together, or disciplines together, in order to come up with solutions to address lead exposure and how to mitigate those properly. Also to provide tools and resources for assessment of not only the program, but also the resources that are out in the community. And then the Flint Registry, funded by the CDC, is a tool to connect Flint residents who are exposed to the water to resources and services that will improve the health and development of Flint residents while promoting wellness and recovery. This registry, much like the 911 registry in New York, is really looking at those who were impacted, what services are there, what are their linkages to services, are individuals following up to those services, and then also evaluating the effectiveness of those services. Health in All Policies itself is a collaborative approach to improving health of all people. It was a policy that, again, started overseas in Europe, and it has reached the U.S. and many states, cities, and counties have enforced health in all policies. But the goal of health in all policies is to ensure that all decision makers are informed about the health, equity, and sustainability consequences of any policy or policy decision. And so in Flint, we got ours passed by our Board of Commissioners in July of 2016. We adapted health in all policies to include health equity in all policies. And again, the 5 elements is health equity, intersectional collaboration, mutual benefit, stakeholder engagement, and then structural and process change. And Flint, although it's on the books in Flint, we are operationalizing it actually at this time, and we will have our first Health Equity and All Policy Summit in June of 2018. The ReCast project, this is the Flint ReCast program is SAMHSA funded and is designed to promote resiliency in the Flint community by supporting families and mitigating the impacts of trauma. So Flint, when we say Flint has been traumatized, there's so many levels of trauma that has occurred to residents. Mothers who boiled water when they received the boil advisories to do so, but then found out that they later, their children became sicker because the lead was more concentrated. Just thinking that mothers thinking that they had a hand in poisoning their children, there's so many levels of trauma. And then not only that, the financial trauma. People's homes have been negatively impacted. People were storing water on layers, like on the second level of their home, and not understanding that they were bending the ball joints in their home. So there's structural costs to people's homes as well. So there are so many different levels of trauma that ReCast comes in, and it deals with multiple layers of trauma, as well as creating a resiliency or using a resilience model in order to help Flint families and their children move forward throughout the traumatic experience of the Flint water crisis. And then finally, there have been several conversations around the lead and copper rule.
Yeah, so one of the things that we've discovered as we were trying to understand the lead and copper rule is that it is held to an engineering standard and not a health standard. Schools are not required to be tested with the federal lead and copper rule, and that's like one of the reasons why you've seen all these articles of different school districts across the country that have had like elevated lead in their water. And currently, the state is revising their lead and copper rule through their promulgation process. And right now, it's at the point where it has been referred to the Joint Committee on Administrative Rules, which is a bicameral, bipartisan group of legislators from the State House and the State Senate. But one of the things that is not in our state's revised lead and copper rule is there is no health impact assessment. So, and it's still not based in health. It's not a health-based standard. And I will say that's a missed opportunity for the state of Michigan.
And that's why the Health in All Policies was such a major component to get it passed here in Genesee County, Flint, because a major component of health in all policies are health impact assessments that should be taken before any law or ordinances enforced by policymakers. And with that, we will turn it back over to you, Peter.
And so, I'm sorry, was I on mute there? Hello? Okay. Can you hear me?
Yes, Peter, we can hear you.
Okay, thank you. So, Captain Naira, can you talk about the current efforts to recover from the crisis that the state is making and how Flint residents are responding to those efforts?
Well, there has been $177 million appropriated by the federal government to deal with the crisis on a variety of different levels, including money for the registry, loan forgiveness. There was only $40 million appropriated for the service line replacement, and even though we are getting our service lines replaced, because the corrosive water has really destroyed the internal infrastructure, so the internal plumbing for people's homes, their appliances that utilize water, and the water mains. There is no money to replace that. And one of the other things, as we are figuring this out, a lot, at the federal level, to replace infrastructure, the only options for communities are through loans, and Flint, our bond rating is so low that we don't qualify for a lot of the federal loans that are available.
And in addition to that, many of the programs that I shared were programs that were collaborative programs that engaged community leaders and academics and some county health department folk to try to create some programs to try to help to move Flint forward. One of the critical things is that this was a man-made disaster. It wasn't a natural disaster. And because of that, we were not we didn't qualify for certain level of federal funds.
Yeah, because it was never a federal disaster declaration. We were ineligible through the Federal Stafford Act to receive any funds. And I would say the travesty of this is because it was only a federal declaration of emergency, that the state is centered in Flint's recovery, and that in itself is problematic because they created the crisis, they covered it up, and there is a deep lack of trust from community folks, to people at the state level, and also people in a variety of agencies around the state that were responsible for covering up the crisis. They are still employed by the state.
Right, and that leads to my second question: how can trust be restored? Trust between the state, the county health department, and the community be restored? What would you like to see? What do residents want to have happen now to restore trust?
So, Peter, that's the magic question, and that is the question we hear at many of the city meetings and town halls, and I don't know if we have an answer. I know to work towards rebuilding trust, you must first acknowledge with full transparency how the trust was broken. And many of the residents still don't feel like the state really took ownership of what has happened. just for example, just more recently, the state has eliminated the water disposition pods that they erected here for the city. And although all homes, all streets have not had their water lines replaced, and then also even with replacing the lead service, the water service lines in the street, as Naira alluded to, the state is not replacing people's pipes in their homes. So the same water that corroded or made sick the pipes that was the service lines, that same water went through people's homes. And so those the pipes in people's homes are compromised as well. And so the state refused to do that. And then on top of that, just the sheer act of closing down the water disposition pods when folks still are not necessarily trusting of the water. Just because you tell people to use filters, we know that filters may filter out lead, but they don't filter out bacteria. So it was for many residents felt it was an insensitive move to do that, knowing that there had not been yet a repairing of trust. So therefore, it makes even repairing trust even more difficult at this moment.
And, I mean, the state has been, like, highly resistant to the idea of transparency. And, and the governor still has not apologized to Flint residents or spoken to them in a public setting.
Right. So it's fair to say that from the community's perspective, the entire response has been somewhat inadequate, indifferent, slow, whatever you want to say.
Yes, and I would say even like the efforts that the community has advocated for, like once the state took it on and implemented it, it perverted the intent of what the community wanted. Like for instance, when the National Guard was passing out water, our National Guard passing out water at the fire station. Once the state decided, people in the community was like, well, Flint residents could do that job. Once the state decided to implement it, they used federal workforce development dollars to hire very vulnerable people and force them to work outside with no shelters, and they had to use the bathroom at a porta potty. So that's just like one example.
Right. So now let me ask Jennifer and Colleen a couple of questions. I guess first for Colleen, you noted that there's no role for public health in safe drinking water prevention. But one of the hallmarks of public health is prevention. So what role could there be for public health in terms of protecting safe drinking water, given the legal regime that you laid out?
I think public health could and should be consulted in the permitting process and in decision-making processes about decisions about treating the water, and if there was so public health in Michigan, local public health departments play a really significant role in other types of water systems, just not the largest, what are called type 1 water systems. And if local health departments and the state health department had more of a role in water regulation for type 1 water systems, I think that would allow for a perspective that is not at the forefront in the Department of Environmental Quality, and that would be more focused on public health.
All right, good. Jennifer, what you laid out some alternatives, I think, for handling municipalities that are in fiscal distress. is your conclusion that Rhode Island is the best model, or is there something else that you think would be appropriate for the reality of handling municipal fiscal distress and the absence of democratic input?
Okay, yeah, I gave Rhode Island simply as an example of a state that had some democratic representation in their law. There are some others that do include that. I don't think Rhode Island is necessarily the standard. I don't know that any of the states that I examined I would hold up as an ideal or a standard. Some do a much better job than others, but I think also it really varied in the different aspects. Some had, instances where local government was to be consulted, but there was no official representation on a board such as Rhode Island had. I think, if I remember, Oregon was one that the governor was to consult with the local government, including the local law enforcement as well, which I thought was an interesting provision. But none of them. I think what would really need to happen is to develop a model from our research to look at the states that seem to have provisions that would be more protective of health, more protective of safety, allow for greater representation. But I wouldn't hold any of them up as the standard that other states should emulate. But rather, I think an effort needs to be made to develop a model fiscal distress law.
That's reasonable. Which leads to a question for actually all four of you. And it's both, I want to frame this both broadly and then more specifically. All of you have talked about the Flint water crisis or crises as being a failure of democracy and democratic input. How do you think we should balance that democratic input with the reality that some municipalities are going broke for a lot of reasons that I'm sure everyone listening in is aware of? So generally, how do you balance that when someone has to make some hard calls? And then the specific question revolves around the Community Ethics Review Board, which Kent described earlier. Is that the kind of mechanism that might be set up to act as a check and balance on the appointment of an emergency manager or some way of ensuring democratic accountability? And I open it to the four of you.
But this is Kent. I'll start it off. There definitely needs to be some type of checks and balances to look at when emergency managers are put in place and where. Some of the fuel behind getting Michigan Public Act 4 repealed earlier on was the fact that many of your cities and communities of color were fearing that emergency managers would be put disproportionately in communities of color, even though there were other communities that were not predominantly of color who were also in financial distress that did not receive emergency managers. So I think that to make it equitable, there needs to be some type of board that has some weight in those decisions, and those that are on those boards need to be fairly represented of diverse and really fairly represent the diverse communities that we have, and especially in the areas in which the emergency manager it may be appointed. So there needs to be some level of accountability and some level of representation in order for an emergency manager model to somewhat feel respectable, but as it is now, it is not. And so the Community Ethics Review Board is just an example from an ethics perspective and a research perspective of how it empowers community to also have a voice in what is equitable and what should be allowed as it relates to research in those respective communities. So I think something similar like that would make sense. I don't know exactly what that would look like per se, but the model itself could be a potential for addressing this issue.
I mean, Michigan's emergency manager law is undergirded by structural racism and the zeal to privatize public assets. And, like, when you look at, you know, like, when the governor came in, like, he had, like, a fiscal, I think it was, like, a fiscal health review scorecard, but the communities that were chosen to be under emergency management, like, that process was not open at all. And I would say, like, a broader thing, at least, like, for Michigan, is like there needs to be some serious reform of how cities are funded in the state of Michigan, because when you look at like a community like Flint, who gets a significant portion of their budget through revenue sharing, versus like other more wealthier communities where if they cut revenue sharing, it doesn't like impact their budget that much. And one of the other things I would like to lift up is a lot of cities' legacy debt is paying for retiree health care and pensions, and there needs to be a way for the state to really take on the burden, at least like for the retiree health care, because like relying on each individual community to bear the cost of that is at the same time where the state makes the decision whether or not they're going to like give more money to communities or if they're going to balance their own budgets. I think that is kind of like a Sophie's choice.
Good. Jennifer, Colleen, any thoughts about?
Yes, this is Jennifer. So I think that it goes back to some of the emergency manager law recommendations that I talked about, really requiring consideration of public health in decision making, bringing in the experts that can speak to the health and safety aspects of these very big decisions, realizing that communities in fiscal distress do need assistance. Generally, assistance from the state can be important in bringing a community out of fiscal distress. In states that I looked at in our research, there were a lot of instances where the state provided valuable resources and technical assistance that would be really helpful in thinking about and developing a plan that could proactively bring a community out of fiscal distress, and realizing that some of these decisions, a single person might not have all the expertise to make an informed decision. So as I talked about, replacing an emergency manager with a panel, with a team of people rather than a single person, and making sure that the decisions aren't only cost-based, that we're really considering the health and safety of them whenever something like this occurs.
I mean, I think as a bottom line, that should be mandatory in all emergency manager laws and fiscal distress approaches. One last question.
Tim did have a comment.
Oh, please.
As well. Yes.
Sorry, I wanted to jump in with one more, which I kind of I mentioned a bit earlier with regard to all agencies, and I think this was true also of the emergency manager, which is just that there were so many complaints coming in from Flint residents that were being ignored at every level of government, and I think that having, at least governmental actors and responses being designed to listen and address the issue instead of kind of trying to get rid of it is really important, and so listening and responding with respect would go a long way towards making sure that voices are heard somewhere, even if nothing else changes in the law.
Good. That's an important point. Thank you. I'm still not seeing any questions from our audience, but I have, I think, probably one last question. Jennifer and Colleen, one of your conclusions, our conclusions in the report, is about inadequate legal preparedness as a contributor to the implementation failures. Can you talk a bit more about what we mean by the lack of legal preparedness and how better preparedness could have it, if not avoided, at least mitigated the ensuing crisis? And sort of talk to both the lawyers and the practitioners among the audience.
Yeah, I think we found in our research that, and especially just in looking at how things unfolded, that it seemed that there was a lot of the barriers to acting. People seemed to think that they didn't have the authority. Somebody else had the authority instead. They might have deferred to each other without having really talked about it. But there's really broad general public health authority in Michigan to monitor, to investigate, to intervene, and there was just kind of the impression that maybe that there were barriers that were not really there, and when we dug into the law, found that action could have been taken sooner, but that there was hesitation to do so, and that seems to be traced to not understanding the full range of legal authority, and public health legal authority is often very broad and needs to be to allow for actions in response to emergencies and public health threats like what happened in Flint. And so it's important for public health practitioners to understand the full range of their authority and to know what tools they have at their disposal, and to have an attorney who they can contact who also understands what they're doing and can provide the assistance with drafting orders or getting a warrant or whatever it is that they need so that they can do their job quickly and when it needs to be done. And so that was just one of the areas where we really found a need, was for public health practitioners to understand their legal authority and be ready to use it quickly when the need arises.
Great, thank you. So we have a question. What, and probably for primarily for Kent and Naira, pardon me, what messaging strategies are Flint activists using to hold the state of Michigan responsible for its negligence in protecting the health of Flint residents?
Well, I'll say it's a variety of things, from continuing to attend meetings and lobbying, and Lansing, our state capital, holding community meetings and doing popular education. But I would say, like, echoing something I said earlier, the state continues to be highly resistant and dismissive of community people, like, actually confronting them or even expressing what's going on with their lives. I mean, personally, I'll just, like, give us a very quick anecdote. A couple weeks ago, I was probably about 6 hours away, and encountered our governor at a public restaurant, and I asked him why did he end the pods, and his response was like, well, change is hard. And they continue to be very dismissive of what what's happening, and I would say that there is a communication breakdown because for Flint residents, and this is like one of the things like with the lead and copper rule, like the state is using these flash in a pan tests that are based in water engineering standards as justification to make a lot of these policy decisions to wash their hands of the whole issue. And this is something that we're grappling with, is that compliance doesn't equal safety. Because when you think of safety, you think of health professionals, and it's really compliance with the water being under 15 parts per billion, because there's still bacteria in the water, other sorts of contaminants that we don't really know about because the state doesn't test for those. And only discovering it through people who are paying significant amounts of money for independent testing.
Mm-hmm. Good. Any other comments in response to that question? I would add a couple of things. First, for those who don't follow the episode closely, there are numerous civil lawsuits that have been filed to hold the state accountable and against individual actors. One against the Genesee County Independent School Board was recently settled for changes in policies to help kids navigate the school environment given exposure to lead, and there are ongoing criminal trials charges filed against both Michigan individuals in the Michigan Department of Environmental Quality, primarily on the lead issues we've been discussing, and against officials from the Michigan Department of Health and Human Services for the Legionella outbreak that we haven't mentioned much. One observation in response to the messaging question is it's been interesting to think about not just Flint residents, but voters. As one commenter mentioned in the chat, the real issue is who gets elected. Initially, certainly Michigan residents generally are appalled at what happened, but there's really been no organized political response, at least not yet. We're in the beginning of a gubernatorial election that's going to be highly contested, and maybe this issue will resonate more once the campaign gets underway. But there's been a striking absence of political pressure brought on the governor and the state legislature. And I don't really have an explanation for it, or at least one that makes any real sense. So I just leave it as an observation. Any other questions from the field? Any final thoughts from the four of our excellent presenters?
This is Colleen. I wanted to add in response to an earlier question that was asked about the role of public health given the framework, if it remains the same. I think one of the important pieces we mentioned in the report, too, was just recognizing the importance of public health using its voice to draw attention to public health threats. So even if the legal environment doesn't change to give more of a preventive role to public health in Michigan with regard to safe drinking water, then the local public health department can be a really strong voice for what it sees going on in the community, even if there's an absence of responsibility in specific areas.
Okay, great. Jennifer, Kent, Naira, any final thoughts you want to share? Okay, well, I want to thank our presenters for doing an excellent job of laying out the legal issues and the view from the Flint residents. And I'll turn it back to Charles.
Great. Thank you so much, Peter. It looks like we're ending a little early today. Again, thank you everyone for your participation in today's webinar, and thank you to our panelists for presenting today. I learned a lot, and I know our attendees did as well. So just a few notes. To all of our attendees, you will be receiving an email that will have the slides and a video playback of this webinar when it's available, as well as a link to our brief webinar survey. So we value your thoughts about today's webinar and what topics you would be interested in for future webinars. You'll also be receiving an email from ASLME with information on applying for CLE credits for this webinar. And finally, our co-sponsors for today's event, the Network and ASLME, are hosting the 2018 Public Health Law Conference at the beginning of October in Phoenix, Arizona, which will include a session dedicated to the Flint water crisis. So make sure you register for that conference. Early bird registration ends today, so be sure to participate in that, and it'll be one to remember. So that concludes today's webinar. Thank you all for attending, and have a great rest of your day.